Hello, awesome staff of the Northwest Kidney Center, particularly at the flagship unit in Kent, with a shout out this month to our friends at the Federal Way West Northwest Kidney Center unit. Today we're going to talk about marijuana use in the dialysis population. Why this topic? It's because marijuana is increasingly being used by dialysis patients, particularly in Washington state, and this has growing implications regarding our patients' health and eligibility for transplantation. There are three objectives to today's talk. Understand the preparations and the pharmacokinetics of marijuana use, recognize the potential medical benefits of marijuana use, as well as understand the potential risks and downside associated with marijuana use in the dialysis population. Marijuana comes from the cannabis plant, which humans have been cultivating for thousands of years. It likely originated in Central Asia, modern Mongolia, Serbia region. The earliest recorded uses in ancient China, where hemp was cultivated for fiber, seeds, and medicinal use. The Emperor Shen Nung's Pharmacopoeia, circa 2700 BC, mentioned cannabis for treating rheumatism, malaria, constipation, and menstrual pain. Somewhere between 2000 and 1000 BC, it spread to India, where it became part of Ayurvedic medicine and religious rituals, and it was known by different names: bhang, ganja, charas, basically used for pain relief, relaxation, and as a sacred offering to Shiva. Cannabis reached the Middle East, Scythia, and Eastern Europe, somewhere between 1000 and 500 BC, and was described in ancient Persian and Assyrian writings and used for medicinal and ritual purposes. Cannabis was introduced to Greece and Rome somewhere between 500 BC and 580, and physicians including Dioscorides and Galen mentioned cannabis for the treatment of earaches, inflammation, and pain. In the Middle Ages, between the 9th and 13th centuries, there were medical uses of cannabis described by Arabic physicians in their canon of medicine. It spread to Africa through Arab traders and was used for pain, malaria, and dysentery treatment. In the 16th and 18th centuries in Europe, hemp was widely grown for rope, sails, and textiles, but not for psychoactive use. Hemp and marijuana come from the same plant family. The difference is their THC content. Hemp has almost none. Marijuana has a lot. Hemp plants are tall, they are thin, and they are grown densely for stalks and fiber. So there was limited recognition at this point in Europe of cannabis as a medicinal or psychoactive plant. That changed in the 19th century when, in 1839, Dr. William Brooks O'Shaughnessy, an Irish physician in British India, formally introduced cannabis to Western medicine. He observed its analgesic, antispasmodic, and sedative effects. He brought samples to England, and soon it was used for pain control, seizure management, and muscle spasms. Between 1850 and 1900, cannabis extracts appeared in the U.S. Pharmacopoeia, and it was widely described or prescribed as tinctures and extracts. In the late 1800s, there were attempts at chemical isolation of cannabis constituents. In the 20th century, these extracts were purified. 1933, cannabinol was first fully isolated by R. Adams. 1964, THC, or tetrahydrocannabinol, was identified as the main psychoactive compound by a couple of Israeli physicians. 1970s, discovery of cannabinoid receptors began. In 1996, California became the first U.S. state to legalize medical cannabis. Since that time, the prevalence of cannabis use has skyrocketed. Cannabis is the most commonly used federally illicit drug in the United States. As of 2025, 24 U.S. states plus the District of Columbia have legalized adult recreational use of marijuana. As a general rule, when you legalize something, you get more of it, and that's exactly what we've seen with marijuana use. According to the National Survey on Drug Use and Health, in 2013, 7.5% of the U.S. population ages 12 and above reported the use of marijuana within the past month, and in 2023 that number had jumped to almost 22%, so a threefold increase, which is pretty scary when you think about it. That means that a quarter of the U.S. population ages 12 and above uses marijuana on a regular basis. The highest prevalence of use occurs among those ages 18 to 25. Since Washington state legalized marijuana use in 2012, the prevalence of regular use has doubled. It was 15% in 2012, and as of 2021, it had increased to 30%. It's almost certainly higher now. In the Seattle metropolitan area, about 20% of adults reported cannabis use within the past 30 days as of 2021-2022 survey. The rates of use among dialysis patients, however, are unknown. One of the reasons marijuana use is so prevalent is because there are multiple preparations available to people these days. 10% of marijuana preparations are used medicinally, 90% are for recreational purposes. The plant has chemicals called THC, which causes the high or euphoria that people feel apparently when using marijuana, and there's CBD, which is used more for sedation and pain control. There are several preparations of marijuana now available for use. Most commonly, people smoke the dried plant, in which case it's known as weed or marijuana. So the dried flowers and leaves of the cannabis plant can be inhaled by smoking it. This allows for rapid absorption of THC into the blood level, and the effect lasts a few hours. Another preparation with which you're almost certainly familiar are edibles. These are food or drinks that have cannabis mixed in, like brownies, gummies, or tea. The effect lasts it takes longer to start, 39 minutes, but can last much longer, up to 8 hours. And there's greater potential for toxicity because it's easy to eat too much because the effects are delayed. Cannabis also comes in preparations known as oils and concentrates. These are made by extracting the strongest parts of the plant. They can look like a sticky oil or wax or crystals. Very strong, often have much more THC content than regular marijuana. Can be used by vaping or dabbing, and there's great risk for toxicity because of the high THC content. That can lead to anxiety, dizziness, and confusion. The active ingredients THC or CBD can be pharmacologically manufactured in a laboratory, and examples include dronabinol, which is prescribed to help with nausea from chemotherapy, as well as hemodialysis, which is made from CBD, and it's used to treat certain seizure disorders among kids. Cannabis can also be prepared as a cream or a lotion, which can be rubbed on the skin to help with pain or swelling. It doesn't usually have the psychotropic effects because the systemic absorption of THC is a lot lower. Let's now talk about what happens to the chemicals after they are either inhaled or otherwise consumed. So the way in which marijuana is absorbed strongly affects how fast and how much THC enters the bloodstream. So for example, when you smoke it or vape it, THC passes through the lungs, enters the bloodstream within seconds, and reaches a peak level in 3 to 10 minutes, and then the effect disappears fairly quickly. But when you ingest it in the form of edibles or capsules, THC travels through the digestive tract, gets absorbed by the intestines, and goes through the liver, a process called first pass metabolism. This delays the onset of action by a lot, 30 to 120 minutes, but the high then often lasts a lot longer, and it can be more intense or unpredictable due to variable absorption and metabolism. Once it's inside the bloodstream, THC rapidly distributes to tissues throughout the body. It is highly lipid soluble, so it easily crosses cell membranes, accumulates in fatty tissue, including the brain, lungs, and body fat. The concentration in the brain rises quickly after smoking, producing the high. THC also binds strongly to plasma proteins, meaning there's only a small fraction that's free in the blood at any given time. Therefore, it is not dialyzable. The liver, and not the kidneys, plays the main role in breaking down THC into several active metabolites, the most important one of which is called 11-hydroxy-THC. And eventually these metabolites are further converted into active forms. The point of this slide is to let you know that the liver is predominantly responsible for metabolizing THC. It is not cleared much through the kidneys, and so having kidney failure doesn't necessarily prolong or delay the metabolism of this medication. Some THC is eliminated through the urine, but predominantly its metabolites are secreted through the feces. It is stored in fat, so it leaves the body very gradually. So if you use THC just intermittently, you'll clear it out in a few days. But if you use it on a chronic basis, it can take months, to get it completely eliminated from the body. As with any drug, there is potential for tolerance that develops with chronic use due to receptor downregulation. There's also potential for dependence. It can be psychological. as well as physical. And symptoms of withdrawal include irritability, insomnia, anxiety, reduced appetite. Typically lasts 1 to 2 weeks, although can last longer in patients who have used it chronically. I mentioned this earlier, but in a little bit more detail, let's discuss the prevalence of cannabis use. In 2024, the prevalence of the use of cannabis was 22.4%, or about 64 million people, according to the National Survey on Drug Use and Health. There's only been one study that's been published in 2024 that looked at the prevalence of cannabis use among dialysis patients. This is a cross-sectional survey of hemodialysis patients who were just asked about their current or former cannabis use and why they use it and whether or not they told their doctors about it. It's a multi-center U.S. study, 643 maintenance hemodialysis patients with at least moderate chronic pain. And of them, 16% reported current cannabis use, while 21% reported former use. Compared to non-users or past users, current cannabis users were younger, more likely to be disabled, more likely to have been on dialysis for more than 5 years, to have a diagnosis of depression or anxiety or any psychological disorder, and less likely to be married. Similarly, in Canada, there has only been one study published looking at the prevalence of cannabis use among dialysis patients. 52 patients were surveyed, and 21% reported cannabis use in the preceding 3 months, and 44% reported historical use. As you all know, there are a lot of symptoms that dialysis patients endure regularly, including nausea, itchy skin, loss of appetite, and cannabis has been tried by a lot of dialysis patients to ameliorate some of these symptoms. Data supports the use of medical marijuana for the following conditions: chronic pain, especially neuropathic, spasticity and multiple sclerosis, chemotherapy-induced nausea and vomiting, appetite stimulation in HIV and AIDS or cancer, and certain forms of epilepsy via the CBD component of cannabis. According to the National Academy of Sciences in 2017, there's substantial clinical evidence that cannabis is effective in the treatment of chronic pain in adults, particularly neuropathic pain, but also cancer pain and musculoskeletal pain. THC activates CB1 receptors in the brain, modulating pain signaling. Multiple randomized controlled trials and meta-analyses have shown modest to moderate pain reduction compared with placebo, and there are multiple formulations available, including oral extracts, an oral mucosal spray, and vaporized cannabis. Cannabis is useful in controlling the nausea and vomiting associated with chemotherapy. THC acts on CB1 receptors in the brainstem, which reduces the emetic signaling. Key drugs include dronabinol and navalone. They are FDA approved for refractory chemotherapy-induced nausea and vomiting, and they're effective in patients not responding to conventional antiemetics. Cannabinoids are also effective at stimulating appetite in certain AIDS-associated or cancer-associated wasting syndromes. THC stimulates appetite via hypothalamic CB1 receptor activation. Dronabinol has been FDA approved for appetite stimulation in AIDS patients. Cannabis is widely used for patients who suffer with insomnia. It helps them fall asleep faster and sleep longer without awakening, although you can develop tolerance with continued use, and the best evidence for its benefit comes in patients with chronic pain and multiple sclerosis. There are case reports and small trials which show a reduction in the intensity of itching, including in dialysis patients. Let's review available data supporting the use of cannabis in dialysis patients. It won't take long to review the data regarding dialysis and cannabis because there are very few studies. In fact, there's no high-quality, large randomized control evidence proving benefit with respect to pain or nausea or appetite or restless leg syndrome, and there are no studies which define safe dosing schedules of cannabis for dialysis patients. Available studies do not assure that cannabis is safe in all dialysis patients, but they don't show clear harm either, but there is some uncertainty about that. And part of the reason is that there is a lot of variability with respect to the cannabis type and the formulation, the THC and CBD content, the route of administration, as well as patient characteristics. There are only 2 trials of cannabis use in the hemodialysis population and none in the peritoneal dialysis population. There was one study that looked at the effect of cannabis use for pain control in dialysis patients. It was a small randomized double-blind crossover feasibility study in 18 patients on hemodialysis with chronic pain. They were given sublingual oil-based cannabis extract, and the primary endpoint was safety, but there was no clear benefit compared with placebo. And that was published in the Clinical Kidney Journal in 2023. There's also one small study looking at cannabis use in the management of pruritus associated with dialysis. It was a randomized double-blind placebo-controlled trial of 60 hemodialysis patients randomized to either placebo or a topical cream containing cannabis oil applied twice daily for 4 weeks. And there was a significantly reduced itching score among the cannabis group compared with placebo. But it was a very small sample size with short follow-up, and more studies are clearly needed. And that summarizes the available studies of cannabis use in dialysis population. There's really nothing else. So there are no studies looking at the effect of marijuana on appetite, nutrition, sleep, anxiety, or other clinical features in the dialysis population. And as I mentioned earlier, there are no human clinical trials using cannabis in the peritoneal dialysis population. It's important to acknowledge the potential downsides of cannabis use in the dialysis population. In the general population, cannabis use has been associated with the development of cognitive impairment, affects short-term memory, attention, and reaction time. There is some psychiatric risk associated with its use, including anxiety, possible triggering or worsening of psychosis in predisposed individuals. It can cause tachycardia and orthostatic hypotension, or blood pressure that falls when a patient stands up. Inhaling cannabis can irritate the airways. There's a potential for dependence, which occurs in the 10% of lifetime risk users. There are many drug interactions, including with a medication called tacrolimus, which is an important immunosuppressive medication used following kidney transplantation. It's one of the main reasons why a lot of transplant programs do not allow for the use of cannabinoids in patients seeking a kidney transplant. There's also potential for fentanyl toxicity. So fentanyl is widespread in the illicit drug supply. It's now the leading driver of opioid overdose in the U.S., and it's often mixed into counterfeit pills and powder drugs to increase the potency. And a lot of people think they're getting cannabis, but instead they're getting a big dose of fentanyl. There's a prevalent myth out there that you cannot become addicted to marijuana, and that is just not true. It can be very habit forming. According to the National Survey on Drug Use and Health, about 1% of the U.S. population, or nearly 5 million people in this country aged 12 and above, are addicted to cannabis. That's about 10% of marijuana users, but 30 to 40% among daily users, and the rates are rising as cannabis potency and daily use increase. Symptoms of withdrawal include irritability, anxiety, insomnia, decreased appetite, nausea, craving. It's hard to treat. About 30 to 50% of people can successfully achieve remission at 1 year with structured behavioral therapy. Another common problem that I see among my dialysis patients who use cannabis on a regular basis is something called cannabis hyperemesis syndrome. This is a condition characterized by cyclic episodes of severe nausea, vomiting, abdominal pain, interestingly often relieved by taking a hot bath or a shower, and it's typically seen among users, heavy users of cannabis. And it can go away if they abstain from using cannabis for a long period of time. And interestingly, these people again take hot baths or showers, so it's very characteristic of the disorder. So no one knows exactly why cannabis hyperemesis syndrome occurs, but it may have to do with sort of dysregulation of CB receptors in the gut or the hypothalamus. It can delay gastric emptying. It affects temperature control, which maybe explains why people like to take a hot shower. And you can also just sort of develop tachyphylaxis, or sort of you get used to the antiemetic effect of cannabis, and you just develop tolerance to it, so it no longer works anymore. Most kidney transplant programs discourage candidates for transplant from using marijuana. About half the programs in the country have various policies regarding marijuana, but about a quarter of the programs in the country just flatly reject all candidates who use marijuana. There are a lot of concerns. For example, with adherence, if you use a lot of marijuana, there's concern that you might be less adherent to medication use or follow-up visits. A lot of psychiatric comorbidity accompanies regular marijuana use, including anxiety, depression, or psychosis. There's a risk of fungal infection associated with inhaling cannabis. Some centers will allow for occasional or medicinal, like cannabis use, particularly if it's in edible formation, but heavier dependent use of cannabis associated with poor medication adherence, higher rates of rejection, and worse long-term graft outcomes. Okay, let's go ahead and summarize what we've learned today. The prevalence of cannabis use is increasing in both general and dialysis population, driven largely by recreational use. Many different preparations of cannabis are available. You can smoke it, you can consume it in the form of edibles, it can be administered in the form of oil. There are pharmaceutical grade cannabis and THC preparations available, and also there are creams and lotions that can be used. Most cannabis is cleared by the liver, but there may be some difference in clearance in the kidney disease population because there is some renal clearance. There are medical benefits of cannabis use have been documented with respect to chronic pain, the treatment of nausea and vomiting that's related to chemotherapy, appetite stimulation, HIV, AIDS, and cancer. In some populations as an antiemetic, sleep disorders, and itching. There are very limited data supporting benefit in dialysis patients. There was one small study that showed that topical cannabis cream may reduce itching. Lots of downsides: potential cognitive impairment, psychiatric risks, respiratory and cardiovascular problems, substance dependence, drug interactions, potential fentanyl toxicity, cannabis use disorder, hyperemesis syndrome, and transplant ineligibility. Okay, time for the monthly quiz. Question number 1, what are the two main active chemicals in marijuana? Yep, that's an easy one. So one is the tetrahydrocannabinol, and the other one is CBD or cannabinol. What percentage of the U.S. population uses marijuana regularly? That's right. According to the National Survey on Drug Use and Health in 2024, 22.4% of the U.S. population ages 12 and above regularly uses marijuana and did so within the previous month. What percentage of U.S. dialysis patients uses marijuana regularly? One study in 2024 showed that 16% of current U.S. hemodialysis patients use marijuana and 21% were previous users of marijuana. In Canada, it's about 21% are current and 44% historic. What are potential medical benefits of cannabis use? Pain control, particularly neuropathic pain, nausea and vomiting is related to chemotherapy, appetite stimulation in HIV as well as cancer, epilepsy management and some types of epilepsy in kids, and some evidence that it may be helpful in pruritus and insomnia. What are potential problems associated with cannabis use? Well, there are lots. So cognitive impairment affects the acuity of short-term memory and psychiatric risk, psychosis, personality changes, fast heart rate, orthostatic hypotension. Inhaling it can irritate the lungs. 10% lifetime risk of dependence. There are plenty of drug interactions, including with tacrolimus, one of the most important immunosuppressive medications used after transplantation. Fentanyl toxicity, because a lot of marijuana is laced with it. Cannabis hyperemesis syndrome, where people get cyclic nausea and vomiting. And perhaps most importantly of all, disqualification for kidney transplant. This includes our October 2025 monthly in-service for the Northwest Kidney Center. Thank you so much for your attention, for your excellent care of our patients. This is Andy Brokenborough. Have an awesome Halloween, and we'll see you next month.